Continuing on in our abnormal behavior section, we're going to look at schizophrenia. Okay, so here are the learning objectives, what we need to find out about schizophrenia. Here we go now. So schizophrenia is actually listed as one of the top 50 myths of psychology, that people believe schizophrenia means split mind. They think it's like dissociative identity disorder or multiple personality disorder, but it's not. It's actually not related at all. When it is translated, it actually means split mind, which probably leads to that confusion. But it is actually a psychotic disorder. Psychotic disorders are those ones where you're out of touch with reality and you're not really sure what's going on. Neurotic disorders are those ones that you know what's going on. For example, anxiety or depression, you know that you're anxious or you're depressed. Whereas schizophrenia is a little bit more frightening because you may not even be aware that this is what's going on with you. So we'll delve into it here. One of the things we have is disorganized thinking. This is a common thing. Disturbed perceptions in schizophrenics. They have delusions. Delusions are thoughts that are not accurate. For example, delusions of grandeur might mean that you think that you're Jesus Christ, okay, or that you're the king, those types of things. So delusions are thoughts. There can be delusions of persecution too, where you're paranoid, where you think people are after you. One of the things that's common with the disorganized thinking we find in schizophrenics is often they'll speak in what we call word salad. They'll be speaking a lot, and it's like they don't focus in on one thing, and they grab little aspects of others. You know, if you think how your brain works, how it tunes into just one thing, when we look at our attention, if you can remember back from previous units, it seems almost like the schizophrenic has a lot of difficulty keeping little details out of it, and it just comes out. And so what they say doesn't make any sense, and that hence the word salad. You know, so we might be talking and there's a brick in the background and we notice the grout between the grit, or the, you know what I'm trying to say, the stuff between the bricks. What's that called? Grout, isn't it? And they may be focused on that, and that may come into their conversation. Now, hallucinations are different than delusions, but just to make sure that you understand, hallucinations are perception without sensory input. So this is people, you know, you hear voices or see images or smell smells that aren't there, or taste tastes that aren't there. So it's any kind of sensory perception without the input that is there. Okay? And when we look at schizophrenics, hallucinations, and we can see that there are things going on inside their brain that makes it very real. Their thalamus is sending messages. If you remember what the thalamus does, it will send sensory messages to the appropriate parts of your brain. And the same kind of brain areas are ignited when you hear a voice for real and when you think you're hearing a voice. So some of the voices sound very real. However, some of them will say they know that the voice is within their head. And unfortunately, they're usually negative kinds of voices that they have. They don't say nice things. It would be wonderful if we had I don't know if it would be wonderful, but it would be more interesting if we had a disorder where when you walk around all day, it just says, hey, you're great. You can do things. You go, guy or girl. But unfortunately, the schizophrenic kinds of voices are usually quite negative, whether they're in your head or outside your head. Other things that happen is they have diminished emotions or inappropriate emotions. Some of them have a flat effect where they don't really show any emotion at all. Other ones will have inappropriate emotions where they may laugh at the news of some death, or they may cry in a situation where they should be happy. And it's often, you know, it's disruptive social behavior is what is going on. Catatonia is the idea that a lot of times they'll just sort of, it almost seems like they just totally ruminate inside their own world. And it's just like they're non-responsive to their environment at this time for often long periods of time. Sometimes engaging in behaviors like, you know, rocking back and forth, or, you know, just certain movements. Okay, so other things that go on when we look at this, schizophrenia is rare, but it's fairly prevalent. When we look at, there's 1 in 100 people develop schizophrenia, and it's a worldwide disease. It shows up in all cultures. The onset of the disease is interesting because we have diagnosed children, at fairly young ages, 12 years old and so on, with schizophrenia, but generally it comes on later in life, in your 20s or so. And there's different types of symptoms. It's one disorder, but it's almost kind of two different things in one. We have chronic schizophrenia and acute schizophrenia. Now, chronic schizophrenia includes negative symptoms. Just going to skip ahead here real quick. The negative symptoms are things that normal people have that schizophrenics don't. So we have emotional control, they don't. Something like lethargy is a normal person is not lethargic, they don't. So it's things that normal people have that they're not aware of. Social interactions we're good at, they are not. Those are negative symptoms. And usually that comes on with a chronic or process schizophrenia. And it's usually, the onset is slower. And it's usually much more difficult to treat. In fact, it's very difficult to treat. Now, acute or reactive schizophrenia often comes on a lot quicker. And the positive symptoms are involved in acute schizophrenia. And positive symptoms are things that schizophrenics have that normal people don't. For example, hallucinations would be one. Okay, that's a very obvious one. Most people don't have hallucinations. Some schizophrenics do. And so that is a positive symptoms. When it's reactive, often it is a lot easier to treat and more successfully treated. When we look at biological causes of this, when we look at the brains of people of schizophrenia, we notice that they have a lot more dopamine receptors. So their dopamine activity is more, there's more activity with the dopamine. Remember, if we have less dopamine, we associate that with like Parkinson's disorder. But if we have too much dopamine reactivity or action, then it's associated with the schizophrenia. And we also know this when we give drugs to schizophrenics, especially with acute symptoms like the positive symptoms, we find that often that will control it. So we limit the amount of dopamine that's happening. Glutamate is also another transmitter that's involved in this, and we'll talk more about that later. The abnormal brain activity and anatomy, when we look at the frontal lobes and the core brain activity of schizophrenics, we find there's different kinds of activity happening. The frontal lobes, again, are affected. And also when we look at scans, MRI scans like we see in this picture, that we see that little dark area is a fluid-filled area, and it's larger in the schizophrenic. We also find the thalamus is actually smaller in schizophrenics as well, and which may make sense with the problem with the sensory overload that a lot of them schizophrenics have. And this may remind you of autism too, and there may be a relation between them as well. The other thing that we're looking at as a cause of schizophrenia, we don't actually have a cause. Again, it's one of those things where there's genetic components and there's environmental components. But one of the things that's been paid attention to is maternal viruses during pregnancy. And studies on maternal activity, when we look at those people that have gone, mothers that have gone through periods of time when there is more influenza, we find that there are more schizophrenics that are born. People in rural areas exposed to more viruses, there is more schizophrenia. So that is probably a cause, it's environmental that hits the person before they are born, so it's in vitro. And this may have something to do with it. So the influence of the flu on the pregnancy may be something that even needs to be looked further. There is lots of research that has been done, and it often points to the idea of viruses causing this or being one of the partial causes of it. Remember the biopsychosocial perspective. People in northern hemispheres, when they're at a certain point in their pregnancy, which is during flu season, there are more people with schizophrenia. And it's just the opposite in the southern hemisphere. When the seasons are reversed, we find there are more in the opposite season. The genetic predisposition all around the world, we see identical twins, okay? There's fairly high correlation with them. We look at fraternal twins, there's less of a correlation. However, there's a correlation, it's all around the world, but the identical twin, this is a strong evidence of a genetic component. So probably a lot of it has to do with genetics and your environment. And some of the studies that have been done modern studies, is we look at families that have a lot of schizophrenia in them, and they follow these offspring of these people, thinking they may develop schizophrenia, and then they look at the results. And this is one of the ways that we will research this. So possible warning signs of schizophrenia. Again, it comes on later in life. Often, a lot of the positive symptoms and things that we see where it really becomes an issue happen when the person moves out of their house and they're on their own. So often it'll go for a period of time without being treated. They may not even be aware. For example, voices they're hearing, they're not voices that everybody else can hear. So possible warning signs is your mother is severely schizophrenic. Birth complications. When we look at difficulties with birth, and we also combine this with poverty, we see a huge increase in actually criminal behavior, which we'll see later. And we also see the disordered behavior increase. Separation from parents, people that have a short attention span, this is a sign that it may show up. Disruptive or withdrawn behavior, emotional unpredictability, or poor peer relations, and just playing by yourself, preferring to be alone. Okay, these are warning signs that schizophrenia could be on the way. The biggest thing, of course, is that you have schizophrenia in your family. It does not mean you're going to get it, but it is a risk factor. Okay, some other disorders too. We look at some of the somatic disorders. So what somatic symptom disorder is, soma, remember, somatic nervous system means how you control your body. Okay, so these are basically disorders that are psychological in nature, but they show up physically. Conversion disorder is we will have some kind of stress, some kind of problem that we're having that's psychological, and we turn it actually into something like perhaps your arm goes numb because of the anxiety you have, or you have stomach aches because of the anxiety that you have. And these people will go to a doctor. There's actually no medical cause for the discomfort or the problem. They're real symptoms. They're not faking this. But often it is some kind of emotional or anxiety type of thing that presents itself this way. Now, illness and anxiety disorder, we used to call hypochondriasis. These are people that will look at, symptoms that they have and then kind of overblow them. You have a headache, their immediately thought goes to, I have a brain tumor. Okay, or they have a stomach ache, automatically they have colon cancer. Okay, and that's how they live their life. They're always in fear of these types of things. Dissociative disorders. Dissociative means that it's like your split brain. It's like you're outside your brain. Okay, so you become separated. A fugue state are those things where people may go off for a period of time and they'll have no recollection of it, and it was like it wasn't them. We've all seen those TV shows or whatever where somebody goes into a fugue state and they go off and they murder somebody and they have no recollection of it. That's what the fugue state is. So all the dissociative disorders have to do with you dissociating from reality. One of the ones that's really common that you guys know a lot about, I think, because it's so interesting, we used to call multiple personality disorder. Its name is actually dissociative identity disorder. This would be like Sybil or the Three Faces of Eve. These were popular stories or movies or books. Actually, if you look at Sybil, it was a book originally. There's a lot of history to that, and there's a lot of controversy over that. Where Sybil, actually her real name is Shirley Mason, who the book was written about, which we discovered far long after the book was written, and the movie, that made for TV movie with Sally Field, was out. When this occurred, there was not a lot of cases of dissociative identity disorder. After the word got out, it increased dramatically, huge, but only in North America, not in countries without it. And in fact, even today, we find in places like China that there are very, very few cases of dissociative identity disorder. Some psychologists would say And when we debate whether it should be part of the DSM-5, say, you know what, this is just possibly another response to PTSD, going into a different personality, so we take on a different role so we don't have to deal with something that is traumatic. And in fact, most dissociative identity disorder people have had something traumatic happen in their life. Is it genuine or not? And that is the question. That's kind of what we've been talking about. And the rates hugely increased after it became popularized through Sybil and the Three Faces of Eve. Is it a therapist creation? If you remember in Sybil, those of you who've seen it, if you haven't, you should watch it. It's long, but it's worth it. But watch the original one with Sally Field because it's way better. Dr. Wilbur was her therapist, and one of the arguments is that she actually created under therapy these extra personalities that Sybil presented with. I believe she had 16 in the end. However, like dissociative identity disorder doesn't seem to happen around the world. It's more where it's kind of been popularized and people know about it. Moving on to our eating disorders, which are actually has the highest morbidity rate of any of our psychological disorders, meaning more people will die from this than any other psychological disorder. We have anorexia nervosa, which a lot of you are probably aware of because it's in the news often. We know famous people that have it. And it's interesting. It's kind of bizarre. Bulimia nervosa, these are the people that will binge and purge. And we also have binge-eating disorder, which was actually added to the DSM-5. These are people that will binge eat, and they don't want to. They don't feel good about it, but they're not necessarily going to purge afterwards. The thing with the eating disorders, when we look at them, anorexia is the person is significantly below their body weight that they should be at for somebody at their, their age, their sex, and everything else. The type of people that get it, it hits anybody. It can hit anywhere. It's not necessarily people that are troubled. It's not necessarily people that are in, more privileged or whatever. Often they're perfectionists. And of course, we have a lot of the social influences through media where we look at, billboards and we look at TV and movie and we start to associate thinness with perfection. And so through the learning theory, we start to associate that and then strive for that. However, nobody sets out to become anorexic or bulimic. Bulimics are harder to determine or to identify than anorexics because bulimics, some of them actually seem to maintain weight for a longer period of time. However, of course, it's a very damaging disorder to them as well. However, these disorders, of course, are very serious, both of them, even though we may take them lightly. The binge eating disorder is, again, something new, but it's been thrown in there. And the causes for this, it's usually an emotional cause. It's not about food. It is not about eating. It's not about, controlling weight. It's more of a control type of thing that a lot of them will talk about. And a lot of it has to do with societal pressures. We're finding it, on runways and stuff for models. In fact, they have rules now that you have to have a certain body mass index in order to go on some of the big runways in the world, in the places, Milan and those places. But a lot of sports too, especially judge sports, gymnastics and diving, we're finding more and more athletes are developing this because their coaches encourage thinness because it's seen as more graceful, and in a judge sport you get higher marks for that. Okay, some other personality disorders. In the personality disorder in the DSM-5, we have things like in cluster A, we have clusters of these. So schizoid personality disorder is an example in cluster A. Schizoid personality are people that actually prefer to be alone. They don't want to be around other people. Cluster B includes histrionic personality. These are attention seekers that are often very high emotionally. So they will respond quickly if they're not the center of attention. They'll make themselves the center of attention. Narcissists, of course, think that they are way better than everybody else, that they're the most important people. And often, again, this is another disorder that we look at kind of lightheartedly. However, it is very serious. Antisocial personality disorder is a big one that we'll look at a little bit more closely in a second. And of course, cluster C is avoidant personality disorder. Okay, so when we look at antisocial personality disorder, there's terms thrown around, sociopath and psychopath. We don't really use those terms anymore. They're not part of the DSM. It's all antisocial personality. The sociopath, however, if you hear those terms, what it used to be, their symptoms are identical. However, it's the onset. When we look at a sociopath, we're saying that it was more onset through environment. Psychopaths was more genetically. So antisocial personality, these are people that don't feel remorse. They act, without the thinking about other people. They have no problem stepping on other people's boundaries. Often they end up in trouble with the law and at school. But others of them, especially, we throw in some smarts, they become very charismatic. And this is also a problem when they are criminals, because they know exactly what to say. Therapy is very difficult because they know what to say to a therapist to appease them. They're very charming. Some of them become very successful as, CEOs of major corporations because they're not afraid to step on, other companies. They're not afraid to fire people. It doesn't bother them. When we look at their brain pathways, we find, again, a lot less activity in their frontal lobes. In fact, when we look at murderers in prison and those that have committed several crimes, we see far less activity in their frontal lobes, which will inhibit emotion and control those things and foresee consequence. So it's almost like they don't foresee consequence and how it fits with others. And of course, many of our, not to glamorize or anything else, but many of the serial killers that have been out there probably had antisocial personality disorder. But because someone has it does not mean they're going to be a serial killer. Okay. However, they don't feel remorse so often in positions. They're going to put themselves in positions where they may be in trouble. Okay. So that is the abnormal psychology unit. And, make sure you understand these disorders. We'll, look through the book, read through things. There's more information, and you never know what's going to be on the AP exam. Okay. Make sure you're reviewing, and we'll see you guys in class. Bye for now.